All right, Michael, I'm going to go live.
Okay, ready.
Hi, everybody. This is Andrew Gerber here from Silver Hill Hospital. I'm the president and medical director, and I am joined today by Michael Grote, our chief clinical officer, and Molly Norton, our director of patient experience and engagement. We've got a few of you already joined, and I wanted to welcome you and thank you for joining on time. Usually a few more people join in the next minute or two, so before we start the program for today, we're just going to give people a couple more minutes. I know sometimes there can be technical challenges as well. I apologize that all these video conferencing tools have their quirks. Microsoft Teams is, probably better than some, not as good as others, but I know Molly is on the phone right now talking to some folks trying to get those glitches ironed out. So let's give it another just minute or two before we get started with the program. So hang in there. We do have a Q&A area of the talk, so at any point, it's live and open now. At any point during the presentation, if you want to put a comment or a question in, please feel free to do so. It is actually helpful for us to know who's listening in. So if you feel comfortable doing so and you want to just say, I'm a parent of somebody in Scavetta House, or my husband or wife is on Main 2, that would be great. You certainly don't have to identify yourself by name or identity or anything, but we know a little bit then about who's joining us. And then of course, if you have particular questions, either about things we're talking about or things you'd like us to talk about, please feel free to put that in the Q&A section at any point as well. We'll probably try to get through the main part of the program before we take questions, but you never know, given that there are 3 of us online and we can all see the questions. Sometimes if one of us is talking, the other person can see the question, type an answer, or even decide that we want to do it before the end. The other thing to note is that when you do post questions or comments, they don't go to the other attendees, so you won't be able to see each other's comments unless we publish them. So if you are asking a general question and would like others to be able to see it, then you can say that and say there's a general question, and we'll do that. But if you'd rather it be more private, then just say that too, and we won't publish it. We won't publish anything that has anybody's name or email address or phone number or anything like that. So just to preserve everybody's confidentiality. We can't see your identity unless you send it to us. It's otherwise an anonymous tool, which is fine. But just to know that if you want us to get back to you about something, then you do need to let us know how to reach you. We are always happy to take calls or emails. We'll give you our email addresses in a little bit. So happy to do any of that. So we're still at a pretty low number. So let me just check in with Molly. Molly, do you know anybody else who's working on joining us?
So everyone that I've spoken to has been given the guides and should be all set. We just got 2 more attendees, so hopefully people are working out the kinks. The people that were having difficulty, I also let them know that I can send them the recording if they aren't able to get in for some reason. So we had that as a backup plan.
Good. Okay. Yeah, a few more people joined, so that's good. So why don't we get started then? Because it's 5 after 1, and I wanna be relatively on time. So I'll tell you what the plan is for today. I'm going to start off and talk a little bit generally about the hospital. Then I'm going to turn it over to Michael, our chief clinical officer, to talk a little bit more about some of our clinical services, particularly now in the times of COVID. And then Michael will turn it over to Molly, who's our director of patient experience and engagement, to talk a little bit about some of the projects that she's been closely involved in serving our patients. At the end, what we've been doing over the last several meetings is having a guest presenter on a specific topic. The guest presenter today is me. And it's not just because we couldn't get anybody else, but I wanted to present. And the topic is actually different types of psychotherapy, which is a research, clinical, and professional interest of mine, and I'll share some slides on that. All of this will be available online afterwards through either video or even just the slides. So don't feel like you need to take notes or anything. But between our introductions and that, we'll aim to go for, let's say, about 40 minutes or so, and then we'll take questions and we can go to 2 o'clock. But as I said, if you have questions or comments or things you'd like to hear about before then, please don't hesitate to write in earlier. For those of you who joined more recently, and I apologize to the others to hear me repeat this, my name is Andrew Gerber. I'm the president and medical director here. I'm a adult and a child and adolescent psychiatrist, and I am joined by Dr. Michael Grote, who's our chief clinical officer, and by Molly Norton, our director of patient experience. You're going to get to see both of them later. Believe me, I'm more than happy to turn the camera to others. But I just, for the sake of speed, I'll take the first segment before I turn it over to them. Okie doke. So, let me start just by giving you a little bit of context. This kind of family town hall that we're doing today is new. We didn't do this before COVID began. And maybe, hopefully, one of the silver linings to COVID is that we are learning new ways to communicate better with our patients and their families. And so we've gotten a lot of positive feedback from families about this. And my hope is that this is something that is useful for you, your family, and ultimately for your loved ones who are here. The challenge that COVID has posed for us, which of course is not unique to us, it's posed challenges to everybody, but the challenge for us is, how do we maintain the very high level and high quality of care that we offer our patients and their families, and have done so for 90 years, and at the same time protect our patients, their families, and, because they're all in close contact, our staff from COVID? If we can't protect our patients and their families from COVID, then of course we can't do the kind of clinical care we want to do, because this is such a dangerous pandemic that's still in many ways quite poorly understood, and our obligation is to keep people safe. So the task of the last several months really has been, how do we balance those two things? How do we keep up the clinical excellence and at the same time provide adequate protection for everybody? I'm going to start and talk a little bit about the protection side, and then Dr. Grote is going to, and Molly will talk more about the clinical side. So let me tell you some of the things we've done, and those of you who've been on campus to drop off your loved ones, and maybe even a few of you who might have visited, because we are starting some visiting with our adolescents, know some of this, but it might be helpful for others. Very early on, we closed down the campus to all visitors, including families, and to all professional visitors in the sense of volunteers. We, prior to COVID, had a very robust staff of volunteers, over 100 people, who would come on and provide various services. But because of the difficulty in making sure that none of them would carry the virus on campus, and the fact that we can't account for all of the families who visit, the only way to do that, and this was really in keeping with national and state recommendations as well as other hospitals, we ended those visits. So that's all the way now since the end of February or beginning of March, and have not allowed those. So that was one. Number two, we were one of the first institutions or hospitals that I know of in the area to go full masking. All of us wear masks anytime we are in the presence of each other as staff or patients, and we expect our patients to wear masks with one another whenever in their close proximity as well. The only reason I'm not wearing a mask now, and Michael and Molly aren't, because we're in our offices by ourselves. As soon as somebody else comes in our office or we leave our office and interact with others, we're wearing a mask. And as you know, that's turned out to be protective in many parts of the country. So we feel very good that we've done that. It's uncomfortable. I don't like wearing a mask all day. I certainly don't like wearing a mask when I'm talking to people or I'm leading a group with patients or with staff for that matter. but it's worth it, because if it can protect people from getting sick and ultimately all that negative consequences you can get from being sick with COVID, then it's essential. Another thing we did very early on is institute twice-a-day testing for all of our patients and staff in terms of symptom checks and temperature checks. So we are constantly checking those things, and immediately, if any staff member has either an elevated temperature or any symptoms, they are kept off campus or quarantined. And if any patients are have symptoms or have a temperature, they're immediately quarantined as well. We are now testing all of our patients using the standard PCR test, which we're able to get back relatively quickly for all incoming patients. Ideally, the patients get tested before they even come here, and we get documentation of that. If they, for whatever reason, they can't, we test them as soon as they get here. We isolate them until the test comes back negative. We also test our new staff, and we test any staff who we have any reason to suspect of any kind of exposure, which at this point is a large percentage of our staff has been tested. We are very proud and also feel lucky with the fact that we have had very minimal positive tests on campus. To date, we've only had two patients test positive over the last 5 months. And both of those were people who were asymptomatic, did not contract the virus here, and were immediately quarantined. So we are fairly confident never spread it to anyone else. We've had several staff test positive, but all whom were identified before they ever came on campus. Certainly were never symptomatic on campus. People do have other parts of their lives and even sometimes work other jobs. So we were able to keep that off campus and keep the spread from happening here. Nobody, patients or staff, had any kind of serious illness, and thankfully we've had no negative consequences from COVID in that way. We intend to keep it that way, not just in this phase, but if we are to experience a second wave in the fall or beyond, all of these policies, we are determined to keep everybody safe here. Those really are the main things. We've also put some structures in place so that if, God forbid, there were some kind of an outbreak on campus, it would be confined within a small group. So we keep the exposures to a minimum, but we have to balance that off, as you'll hear more from Michael and Molly, with making sure that people have access to the kinds of mental health care that they came here for. Couple other things I wanted to mention. We did move our outpatient completely virtual, that is off campus, so that's another way to minimize risk. We are now starting conversations about how we might bring some of the in-person contacts back in a very contained and careful way. So just in the last 2 weekends, we have had, in a very structured and socially distanced environment, some families visit their loved ones in the adolescent program because we felt that that was a place where it was most acutely felt. We are working towards doing that in a very carefully controlled way in the adult program, not this weekend, but potentially in 2 weeks. But that's still under review, and obviously we're only going to do that if we can guarantee that it doesn't provide risk to our patients or to their families. So we take this very, very seriously. I think that's really what I want to cover for now. I am going to turn it over next to Dr. Grote, who'll tell you a little bit about our clinical services, particularly how we've been able to adapt to all the things I just mentioned and make sure that all of our clinical services are still of the highest excellence and quality. So on that note, let me turn it over to you, Dr. Grote. I'll put your video on and
Okay. Thank you, Dr. Gerber, and appreciate your overview and your commitment to ensuring that all of us are working with in alignment towards not only providing top-notch clinical care, but doing it in a safe, effective manner. So one of the opportunities we've had as an organization is to really rise to the challenge of providing excellent clinical care while we maintain a safe environment for our patients. And we have, in many cases, made adaptations that allow us to maintain the kind of in-depth contact that we know people value, and maintain safety. So, for example, I provide psychotherapy here to patients. I lead groups, and there's a particular patient that I work with who we've looked at this closely together. Has had a lot of concern about whether or not he can see my face and read my face. So what we developed was a way of meeting together that allows us to sit at a considerable distance in a ventilated room, and for me to have him be able to see more of my face than having a mask cover all of my face. And again, that's done very, very safely with about 15 feet between us in a well ventilated space. And we've been looking at how do we build on the connectedness that we know is essential to this work and do it in a safe way. And I'm very happy to say that to date there's only 2 patients I can think of since March who have tested positive for COVID, and one of whom we worked with until that person was feeling better and we safely discharged. We've had a remarkably extremely low infection rate here at the hospital, and we feel extremely good about that. We test everyone coming in. The stats I have as of yesterday is everyone we have brought to our front door here and tested, they've all tested negative for COVID, and that's in addition to the extensive screening that we do on every prospective patient. And the screening includes assessing temperature, assessing any kind of symptoms, assessing the social context that they have, assessing whether they've been in any kind of place that might be considered higher risk, such as being in a crowd, assessing to what degree they have been in contact with anyone who's known to have COVID or suspected to have COVID. So we're doing a lot of pre-screening of individuals prior to their even getting here. And that is on top of the fact that when they get here, we do another set of screening, another set of temperature checks. They meet with our nursing staff and our physicians for additional screening. So we continue to work hard. We remain vigilant, although as in the state of Connecticut, I think we feel a degree of pride that we have flattened the curve. We know that we cannot at any day or any moment lose our vigilance. And so that commitment remains. At the same time, what remains is our commitment to high quality care. And, Molly and I work very closely together. Molly's hearing from people on a regular basis about their experience here in treatment. I'm hearing from patients on a regular basis about what their experience is like. I'm talking with families. I'm talking with our clinical staff. We have a lot of different input sources, and we take that input and we not only hear it, but we respond to it. So, one thing I can say in the big picture that I'm very proud of and feel very good about is that in the last 3 months here at Silver Hills, since the pandemic has really spread throughout the country, or even though the infection has spread, we have maintained our focus on solid clinical care. And we continue to look at ways we can make adaptations. And I'll just comment on one of those. We have begun piloting visitation for people to see their kids at the K House, which is our adolescent program. It has had some ups and downs. The up part there, that we have found a way for family members to safely meet their family members outside, and obviously a very well ventilated space, being outdoors. However, there are natural human impulses to want to hug and connect more closely, and that's where it gets very, very tricky for us, is because we are again upholding guidelines and a set of standards around the social distancing, the wearing of masks, and we need everyone to adhere to that to maintain the safety of all. So it's been a challenge, trying to, it feels unnatural to all of us to not go with our normal human impulse on some level. And right now we're in the process of talking through and thinking through how do we extend more visitation for our adult programs. And, we're working on figuring out, okay, when people are here visiting, where would they use the bathroom facilities if they needed to? And how do we safely make sure that there's access to a bathroom? How do we ensure its cleanliness throughout the day, using infection control? I mean, these are all things we have to think through and we take very, very seriously. And we want to have thought through before we make visitation more broadly available. And these are, complicated decisions. And we are working hard to figure this out and figure it out as quickly as we can, as safely as we can.
Fantastic. Thank you so much, Dr. Grote. That was really, really helpful.
Yeah.
Molly, can I turn it over to you now for some thoughts?
Yes. Hi, everyone. My name is Molly Norton. I'm the Director of Patient Experience and Engagement here at the hospital. And just adding on to what Michael said, normally Michael gets to talk about all the fun stuff, and today he was had to cover some difficult topics with visiting. But I wanted to add some of the wonderful activities that our patients have been doing during COVID that we didn't have before. And Dr. Grote has been a huge part of implementing some of those activities. He's here pretty much every weekend running virtual bingo group with our patients, movie nights. His wife has done jewelry making groups with people. So a lot of awesome stuff. I was over at the Steward program this morning, and they were talking about the virtual book club that Dr. Petra Pilgrim runs with the residents over there, and that's available to the TLP and residents in the other houses as well. So a lot of virtual stuff, but a lot of creative stuff has come out of this, and we continue to strive to find more activities for our patients. Another project I've been working on that I'm really excited about is that Silver Hill is starting an internet radio station with an actual studio on our grounds. And we're in the very beginning stages of that, but that's something where down the road, the patients here will be able to participate in the radio station and have this nice community project that everyone works on together. So a lot of exciting stuff. I want to leave enough time for Andrew's presentation. I know you're all looking forward to that, and time for question and answer at the end. So thank you again for being with us today, and we look forward to speaking to you more. Thank you.
Great. Thank you, Molly. So let me see if I can get both my slides and my picture. This is always a little bit of a challenge. Whoops. I have Molly's picture and my slides. So wait, I'm going to try. Let's see, that's me. And now I'm going to put up my slides. Let's see if that works. Okay, good. Now I think hopefully you should be able to see my slides on the big and then a little picture of me next to it. All right. So, this is a topic that is near and dear to my heart. Actually, before I even went to medical school, I had done graduate work and received a PhD in psychotherapy research. And it's long been of great fascination to me that you can change people in such a fundamental way by talking to them. And I think that sometimes when we get into the jargon and we get into all of the technical details of psychotherapy, which we'll do in just a minute, you sometimes forget just how incredible it is that doing this thing that is so commonplace, that seems so everyday, that is sitting with somebody and talking to them, that you can bring about changes in fundamental ways. Now, from another perspective, well, isn't that obvious? Don't we do that all the time with our loved ones and our friends and our children and our parents and so on? But I think that it's a little bit harder to remember that can act just the same way a medication can, or can act the same way that some kind of more physical intervention can. In fact, at the very end of this talk, I'm going to show you a couple slides about brain changes in response to psychotherapy, which is some of the research I've been involved in, to really drive home the point that you are changing someone's brain when you talk to them, in particular in the way of psychotherapy. But of course, when we talk about psychotherapy, we're not just talking about a casual conversation. And this is some of the things that sometimes where it gets a little bit important to draw distinctions, because if you could heal someone's psychological illness or addictions only through an untrained casual conversation, you wouldn't need therapists. You wouldn't even necessarily need the professional environment that we provide at Silver Hill. There's enormous training and expertise and research that's gone in over the years to how to do these conversations in a way that is as efficient and targeted as possible. In the moment, it might just seem like a regular conversation. In part, you might argue some of the art of psychotherapy, and there is art as well as science here, is in making it seem like it's no big deal, yet actually having profound impact and changing people in positive ways. So, if you ask the broad question of what is psychotherapy, I would argue that it's all these things that I list on my slide. It's talking, it's support. Those don't sound like they're that specialized, although I would argue to do them in the right way at the right time with the right person is. It's a relationship. It's not a usual relationship. I was about to say it's not a normal relationship. Well, it's normal for some of us. It is a relationship, but a different kind. It can, but doesn't have to involve further exploration. It can, but doesn't have to involve insight. And I would argue that much of psychotherapy is a kind of training oneself, training one's brain, training one's mind to overcome difficulties. That doesn't mean, by the way, that just because one can change things by talking about them, that they are only in one's head, right? That I'm putting that in quotes because that can be used in a dismissive way. I suppose it's all in our head in the sense that it's in our brains, but of course, people don't choose their illness. People come about their illnesses through a variety of means, including the genetics they inherit, early life experiences, random changes in their brains that we don't fully understand, a whole lot of other experiences that can happen in adolescence into adulthood. We don't fully understand how all these psychological and psychiatric difficulties arise, but we do know that however they arise, psychotherapy has been shown to be helpful as part of a larger treatment picture, okay? So I'm going to ask some simple sounding questions, but some often have more complicated answers. With whom is psychotherapy done, right? You might start by the kind of old-fashioned, I would argue, model of a therapist sitting in a suit and tie with a patient reclining on a couch, and that's often associated with the old psychoanalytic tradition going back 100 or more years. Yes, psychotherapy can be done with individuals, but psychotherapy can be done in groups, as you were already hearing about from Dr. Grote. Psychotherapy can be done with families. Psychotherapy can be done with couples. Any configuration has its advantages or disadvantages. One is not more or less psychotherapy than the other, but they're different kinds and they're different appropriateness for different situations. In general, and you'll by the end of my talk, you'll hear this in many different ways. I am a firm believer that there is value in almost every approach, that it's not about the right approach and the wrong approach, which as tribal human beings, we sometimes fall into, but rather it's about what's the right approach for that individual in that particular situation at this particular time. And ultimately, you need a wide range of tools, techniques, models in order to have the right thing associated with the individual. Where is it done? Well, until recently, a lot of people might have said, well, really in person is what real psychotherapy is. But I would argue that was probably never true. Long before COVID, many therapists, whether they spoke about it publicly or not, were doing psychotherapy by phone for very practical reasons. Is that the same as sitting across from someone? Of course not. But sometimes it's more practical. And even sometimes, and those of us who've done it will tell you, there are certain advantages. I don't suggest we're going to replace in-person psychotherapy forever by phone, but I imagine it'll always be there. Now, interestingly, with modern technology, and particularly in recent months, we have been doing more psychotherapy via video conference, that is using Zoom or Microsoft Teams or some other HIPAA-compliant platform. And I think most people, therapists will tell you, and probably patients as well, that online is better than just phone, not as good as in person, but certainly can be more convenient, particularly at a time when we're doing our best to limit in-person contact and contagion. One could get into long discussions, and we have already at the hospital. Well, what's better, doing psychotherapy in a mask in person where you can't quite see each other's faces, which is tricky, or doing it unmasked via conference? And I don't think there's a simple answer one way or the other, but again, I think it's better to have more options. This may sound a little scary to some of us who are a little older and didn't grow up with text messages, but there are even people doing psychotherapy via text right now. In fact, if you probably counted how many people in the United States at the current time are engaged in some kind of psychotherapeutic relationship, I would not be surprised if what you learned was that the largest proportion are doing it by text. Is this conventional psychotherapy? Of course not. But there are hotlines like Crisis Text Hotline, which is a wonderful nonprofit service available. It doesn't take the place of more intensive psychotherapy that one would do in person or online, but in some cases it can be very helpful to individuals. And all of these things are things we're learning more about, particularly in this era where in-person has become challenging. Now, who can be a psychotherapist? There's no one answer to this. Psychiatrists historically were well trained in psychotherapy up through, let's say, about the 1980s or into the 1990s. Interestingly, with the explosion of medications and neuroscience, most psychiatry training programs moved away from an intense training in psychotherapy because they had to make time for more training in neuroscience and psychotherapy. That may have had some advantage to the use of medications and neuroscience, but it probably was a disadvantage to how well trained many younger psychiatrists are in psychotherapy. That said, many of us, myself included, and certainly many of our doctors here at the hospital, got graduate training in psychotherapy past their psychiatry trainings. So one can be a good psychotherapist as a psychiatrist, but not necessarily. Psychologists like Dr. Grote are very well trained in psychotherapy, and that continues to be a core aspect of training in psychology programs. There's still variability there too, but in general, I would argue psychologists probably have most consistently the highest level and most years of experience in training psychotherapy. Social workers do train in psychotherapy. It's a slightly shorter training, but most social workers have a lot of then practice and training after their social work training. I'm realizing as I'm giving this list that I left out an important category because I'm looking at Molly right now. Molly is a trained licensed mental health counselor, correct, Molly? Who also have training in psychotherapy. I should have put them on the list too. It's a newer category, and Molly maybe can add a little later about that kind of training. Nurses may have psychotherapy training. I happen to be on a call just today with 2 expert psychotherapist nurses, but there is some variability. And interestingly, there's quite a lot of clergy, pastoral counselors, ministers, rabbis, imams who have psychotherapy training as well. And no doubt, you think to yourself, that's a large part of the job of many clergy is counseling individuals in their congregations of various kinds. So it makes sense that psychotherapy, this is not an exhaustive list. I'm sure I've left out many other categories, but what I would encourage you to do is rather than think about, oh, you have to be a psychiatrist or psychologist or social worker to do psychotherapy, but rather ask people the kind of training and experience they've had, because at the individual level, that can be quite meaningful. Okay, now to get into the question of brands of psychotherapy. Now I'm making a statement even in the title of this slide that some of you might be aware of. There are many different names for what are often called evidence-based psychotherapies, meaning psychotherapies that have named themselves. Most commonly, they pick a 3-letter acronym that people can remember, and I've listed some of the big ones here. And then they talk about the research that supports those particular kinds of psychotherapy. Now, I am all for that. I think that we have learned an enormous amount from these individual psychotherapies as they have been developed in one form or another really over the last 100 years. However, one has to be careful not to be fooled that the name alone is what tells you whether it's a good psychotherapy or the right psychotherapy for you. These are brands, meaning if you want to know, is this the right toothpaste, it probably doesn't all come down to whether it's Colgate or Crest, okay? Those were developed by different companies. They have a lot in common. They have some differences, but they are branded in that way that if you're Colgate, you want to portray yourself as very different than Crest. And if you're Crest, you want to portray yourself as very different than Colgate, even though we also know that they're both perfectly good toothpastes, okay? These psychotherapies are all good psychotherapies in the right context. Here's where my toothpaste analogy breaks down. I don't think there are specific kind of teeth that do better with one than the other, but there are specific types of difficulties and situations and patients and therapists who do better with one of these brands than the other. Ultimately, the goal is to have a treatment environment where there are multiple possibilities for different kinds of psychotherapy so that the treatment environment can recommend and then implement the kind of psychotherapy that's best for the individual. Now that's hard to do, right? Each one of these can often take years of training, and to have a staff that's well enough trained that you have at least some people who can do all these different things is not easy. Most environments don't have that. Most environments do tend towards one or two of these. And that doesn't mean those aren't valuable, but it does mean you have to be a little careful with the issue of if you're a hammer, everything looks like a nail. I would argue you never want to be in the situation where the person you're going to for help only knows how to do one thing, because as good and as honest they might want to be, there may be a tendency to then see the problem largely through the terms of what they know and not through all the different lenses. We certainly strive here at Silver Hill, and we're not perfect. We're on the way to this, but we still have room to go. We strive to be able to offer as many different types of psychotherapy as we can, as long as we can do them individually well, and tailor those to the individual. Now, let me say a little bit about some of these. I'm certainly not going to give any kind of in-depth description of each one, but I want to at least give you a flavor. Cognitive behavioral therapy, which has really been around since the 1960s. Many of these therapies are associated with individuals, and so cognitive behavioral therapy is associated with a founder named Aaron Beck. It believes very much that the cognitive, that is what we think consciously about, and our behaviors, that is how we navigate whether we're doing something or avoiding something, can be used in a very structured way to influence our illness, whether it's anxiety or depression or panic or eating disorders or addictions or virtually anything you name. Now, cognitive behavioral therapy, because it's been around now for some time, has grown, and there are many different versions of it. So it's really not accurate to say that any of these are a single kind of psychotherapy, certainly not CBT. It is many, many, probably hundreds of different things. And they early on embraced an empirical model, a research model that has done very well. Dialectical behavior therapy, which is in many ways an offshoot of CBT, was designed in the 80s into the 90s by a woman named Marsha Linehan to be more specifically for individuals with what at that time was being called borderline personality disorder. So not quite the same domain as CBT, but more narrow to borderline. Now, over the years, DBT has been adapted for many things. So at this point, even though there's quite a bit of overlap between DBT and CBT, there are applications for DBT that are also somewhat distinct, okay? Psychodynamic psychotherapy or psychoanalytic psychotherapy is arguably the oldest kind of formalized psychotherapy, tracing its roots back to Sigmund Freud, the end of the 19th century, and being really codified at the beginning of the 20th century, and originally often being called by the name psychoanalysis. We tend to use the term psychodynamic psychotherapy or psychoanalytic psychotherapy to connote the more flexible version of psychoanalysis that involves seeing people once or twice a week, not just 3 or 4 times a week, but they're all closely related one with the other. There was an old kind of argument that said psychodynamic psychotherapy was proven wrong, that Freud turned out to be wrong, or even that there was no evidence to support it. None of that is true, actually. Psychodynamic psychotherapy has been tested, has been shown to be effective in many situations. Not quite as much research as the first two, but still quite a bit. And still is a very important part of a lot of psychotherapy for different conditions that is done. Interpersonal psychotherapy, or IPT, is an interesting kind of a combination with a little bit of the CBT, a little bit of the psychodynamic, but was designed by someone named Gerald Klerman and his wife Myrna Weissman, first at Yale and then at Cornell and Columbia, and involves relationships more than traditional CBT, but also has more of a structure than traditional psychodynamic psychotherapy. Mentalization-based therapy was developed by someone named Peter Fonagy in London, happened to be someone that both Dr. Grote and I studied with, so we know quite well. He actually sits on our board of trustees. By the way, I have the wrong acronym there, MBT instead of IPT, and also has a kind of mixed identity, roots in psychodynamic psychotherapy, but elements of other forms of psychotherapy as well. Acceptance and commitment therapy, or ACT, is a derivative, what's called a later third generation derivative of cognitive behavioral therapy, and speaks more about having a certain acceptance component and accepting that which one cannot change. You might hear some roots of addictions treatment in there. And then last but not least, for this particular incomplete list, is prolonged exposure of a more specific kind of therapy for post-traumatic stress disorder or certain kinds of trauma that has been associated with the name Edna-FOA and has been widely used by our VA system. I could probably fill about 5 more slides with other lists of psychotherapies, but this is a pretty good start and probably accounts for a lot of the psychotherapy that's done out there, and certainly a good part of the psychotherapies that are done here at Silver Hill. Just to give you an illustration of those, and it includes, there really is a family tree, and this, I didn't take the time to design a more comprehensive one, but this is one I found online, that you can actually see the ancestors of psychotherapy in things like French neurology, learning theory, humanistic, person-centered, or family systems, and then other psychotherapies really being derivative. The truth is, it's a very intermingled family tree. It doesn't show here, for example, that Aaron Beck, who founded behavioral and cognitive behavioral therapy in that box, was actually a student of psychodynamic psychotherapy before he started to use this term here. That Jerry Klerman was also influenced by psychodynamic, not just by Ryle or cognitive analytic. So there's a lot of mixture between these. Certainly Mnuchin up here in family systemic was also trained psychoanalytically and so on. But really there's a lot we all have to learn from one another. And ultimately what I would argue is that you want to be in an environment where there's enough expertise on different modalities that the right modality is ultimately prescribed, just as you'd want the right medicine prescribed for your loved one. All right. Now, what about the research? I've alluded a few times to the fact that research has been an important part of the field. I'll give you a simple version of what's obviously a much more complex story, that when different kinds of well-formed psychotherapies have been measured against one another, they virtually always tie. Now, that may sound like a very nihilistic and disappointing result, but let me explain it a little more. We as psychotherapists and as providers are committed to doing the best psychotherapy we can for an individual. And what it turns out is that whether I am following a manual that tells me to do psychotherapy A or psychotherapy B, as long as I'm well trained and I have the patient's best interests at heart, I can use different manuals to provide the best psychotherapy for that patient. And the rates at which they improve are the same if a different therapist uses a different one of these manuals, right? Now, that doesn't mean psychotherapy is worthless. It doesn't mean that if I compare psychotherapy against someone who doesn't know what they're doing or is following a manual that is intended to not be helpful, absolutely there's a difference. Psychotherapy does better than no psychotherapy, but good psychotherapies generally tie. Now, does that mean it's absolutely arbitrary which psychotherapy you do? Of course not. And as I was saying earlier, as a good clinician, you want to tailor the psychotherapy to the individual. But the manual or the name or the brand of the therapy isn't so much what tells you how to do that. Within the different manuals, you can come up with different ways of doing it. So you want someone who has a structure, who is trained and adheres roughly to certain psychotherapies, but beyond that, you really want to go with the individual situation. And research isn't really, or certainly not randomized controlled trials, are the best way to see it at that more detailed level. I myself have done some research in this area, and I'm showing you two studies we published here, 2011 and 2012, where we demonstrated that psychodynamic psychotherapy and cognitive behavioral therapy, at least for depression, are essentially equivalent. And that was an important finding that I believe has helped break down some of the silos in this field. By the way, there is a shorthand name for this in the field, which, in case you're interested, Saul Rosenzweig, way back in 1936, who was a psychotherapy researcher, quoted Alice in Wonderland by Lewis Carroll and said, everybody has won and all must have prizes. And if you know your Alice in Wonderland, you may know that that was said by the Dodo bird. And this is an engraving from Alice in Wonderland. And so since then, this has been called the Dodo bird verdict or the Dodo bird effect, meaning that different psychotherapies generally tie when you compare them one to another. All right. By the way, there's also been some questions out there at times, the tribal nature of things. Oh, my studies are better than your studies. Well, we also in our study in 2012 compared how good these studies are and found that studies of psychodynamic psychotherapy and cognitive behavioral psychotherapy are basically as good as each other. The blue squares and the red diamonds here are completely overlapping in terms of overall quality. Now, let me just say a last few things before we run out of time. This is a kind of a technical slide, but I thought I would just let you see it, and maybe at some point we'll have a chance to discuss more. If brand names don't explain everything, well, what does? How does psychotherapy work? And the honest truth is there's a lot of competing theories. But I would argue that the real leaders in the field are folks who have said that probably what works in psychotherapy is more similar across different brands than it is different. And even if you use different terminology in CBT, than DBT, than psychodynamic, than IPT, the name of the thing matters less than what it actually gets at. So I use a framework that basically boils down the mechanisms of psychotherapy into three general categories. I won't go into detail, but I want to give you a sense of them. Part of the effective psychotherapy is what I might call exposure, or the technical term is exposure and response prevention. That is, the effectiveness of psychotherapy relies on the fact that we as human beings avoid things that are unpleasant to us. And sometimes avoiding those things makes things worse. And a lot of that avoiding isn't just places and people, but it's avoiding even thinking about certain things. We don't want to think about things that make us feel bad, and that undermines our ability to make changes in our lives. Imagine we can all relate to that. So all psychotherapies, at some level or another, try to create a safe environment where the individual can sit in a therapist's office or online or on the phone or wherever, and talk in a non-threatening way about some of those things that he or she may have wanted to avoid talking and thinking about. And that the person across from them, the therapist, is non-judgmental and kind enough to allow them the space to say things that they might not be able to say or be too afraid to say in other contexts. The more you do that, the easier it gets, almost like avoiding almost anything. Okay, that's one piece of psychotherapy. It's by no means the only piece. Another important piece is relationship modeling. And by that, what I mean is the following. We all know that there are some things that we learn that we don't learn just by understanding them. We learn by practicing them, right? Nobody ever learned how to play tennis by reading a book about tennis. or how to make their golf swing better by just watching a video about golf. You get better at tennis or golf by practicing, by swinging the club or by swinging the racket and doing it over and over again with the guidance of somebody who can help correct you and make sure you're practicing in the right way as opposed to practicing in the wrong way. Well, relationships are no different. We all learned how to have relationships, not by reading about them, but by having relationships with our parents, with our siblings, with our cousins, with other people we knew. And some of what we learned was helpful, and some of it wasn't. Some of it may have worked in the moment, where we were in our families, or how our parents were, or how our siblings were, or what environment we were living in. And some of that didn't generalize well, and as we're adolescents or adults, we need to do it differently. But because you don't just change a relationship by knowing that, you got to practice doing it differently, and practicing relationships is difficult. But psychotherapists do that with you. They practice having healthier and more functional relationships, even though they're not quote unquote real relationships. That's not the goal, is to have a good relationship with your therapist. But the goal is to learn how and to practice having a better relationship, not just with your therapist, but ultimately with everybody else in your life. And a lot of psychotherapy is spent doing that. Last but not least, we all have a story of our lives. Any one of us, if you asked us to tell us the story of where we came from and what we struggled with and what we're good at, and what's going well and what's not going well, we could all tell a story. But stories are stories. In other words, they can't possibly capture all the details in our lives. And sometimes our stories are problematic. Sometimes we tell stories that keep us more narrowly constrained than we want to be. A story that I'm always going to fail at something, or a story that these kinds of relationships are never going to work out the way I want. And one of the things that a therapist can help you do is to retell that story, to shift that story, not fundamentally, and certainly not by fiat. The therapist doesn't sit you down and say, your old story's wrong, here's the right story, because they don't know. But to help you explore a flexibility in how you tell the story of your life. Because ultimately what matters is what you do next. And your story is important, not because it's the past, but because your story helps inform how you're going to behave going forward. And that's also a fundamental part of psychotherapies too. Okay, now I really need to wrap up, so I'm just going to show you a couple more slides. Does psychotherapy change the brain? Yes, we know it incontrovertibly. There have been literally hundreds of studies now that show brain changes in response to psychotherapy. They're not bigger or smaller than the changes you get in response to other interventions like medication. They are very real. They are very permanent. What they mean, we don't know yet. This brain imaging technology, this happens to be an example of some MRI work that I did myself, is very hard to interpret. There's a lot of different answers to that question, but hopefully in the coming years, we're going to know more and more about that. So what is the future of psychotherapy? I would argue part of that is a future of understanding underlying illnesses better. And I do believe that as we understand the brain better, we're going to be able to target psychotherapies more closely. This happens to be a study done at Cornell about theoretical subtypes of depression and anxiety. We all know that every depression isn't the same and anxiety isn't always the same, but we've really never had a good framework for how to break it into groups. Well, it turns out that when you look at brain organization, you can do this. What I would suspect is that some types of depression and anxiety respond better to some kinds of psychotherapy. We haven't matched those up yet, but that is certainly coming in the years to come. And then last but not least, it's not all about brain dynamics, or at least let me say it's not all about brain imaging. It's also about content. It's also about how we organize meaning in our minds. And there is an exploding area, interestingly, that a lot of which comes out of cognitive science and artificial intelligence research, that is about how to understand meaning in our minds, particularly outside of awareness. And a lot of very, very smart people right now are devoting time to understanding these dynamics. I believe that ultimately we will need this kind of a science to understand the mechanisms of change in psychotherapy. We'll have to include the brain aspect as well, but we also have to include the meaning aspect. And my suggestion is to check back in a few years, and I think you're going to see more and more great research being done in this area. So on that note, I am going to stop. I will turn the video back over to me. And why don't we see if there are some questions, and it can be on psychotherapy, but it can be on anything you like, and then we will let you go. Actually, you know what I'll do is, if you don't mind, maybe I'll turn it over to you, Molly, because you've had a chance to look and see if there's anything else that's come up that you'd like to address. It gives me a chance to catch my breath a little bit. I think you're on mute, Molly.
Yeah, let me get myself off mute. So I'm looking through the Q&A now. Hopefully everyone has been able to access the Q&A function in Teams. So there was a good question that was posted about going back to COVID and our precautions. Do we consider using a face shield instead of a mask so that patients can see your face? And that's a really interesting idea. If so much of the therapeutic relationship is expression and being able to see each other and see each other's faces, it's an interesting suggestion. And actually, Andrew answered this one privately, but I'd like to share his answer. He said, good question. The recommendation from research has been that a face shield alone is not sufficient. At close distances, one needs a mask too. There are some masks that have a clear front, which we plan to explore. So that's really interesting. I didn't know there were masks that had a clear front. So I look forward to learning more about that. There was another question from someone who had attended our 3-day family program for the dual diagnosis TLP. The question is quite lengthy and specific. So what I will do is, for that individual, let's connect after this and I can address your question offline. It's just a little specific for this forum, but definitely very important to address. Let's see.
There's one more question, Molly, about psychotherapy for psychosis, which I answered a little bit privately, but why don't I say something general about it? I didn't cover it in my presentation. There was just, there's so many specialized areas, but the questioner noted quite thoughtfully that we now know that there are certain kinds of psychotherapy that are very helpful for psychosis. And this was often thought not to be the case. In other words, there were people who said, well, psychosis is, that's a quote unquote brain disease. How could talking change that? And, just to understand the question, to say, yeah, that's right, that we certainly don't think of psychosis as caused by just a bad environment or parenting or talking. That's not the cause of it. We know there are brain origins, and you don't eradicate an underlying severe disorder that includes psychosis just by talking, but you help psychosis, really a bunch of all types, through talking and psychotherapy. And CBT for psychosis is one of those. It's not the only, but it's one of them. And there's a number of different theories about how talking or psychotherapy helps psychosis. One is the idea that there is actual meaning to the psychotic delusions, and talking about them actually gets them out and engages them in a meaningful way. I think there's a lot of merit to that theory. It's not the only theory, though, about how therapy is helpful. I think there's also a lot to be said for the supportive aspects of psychotherapy, meaning that people with psychosis need somebody to validate them and not contradict them, and also help them in very practical ways about how to navigate the consequences of being psychotic, which can be pretty devastating for the individual and also their environment and their relationships. So I think probably there are many mechanisms by which psychotherapy for psychosis is helpful. And I offered to put this person in contact with somebody on our staff who has more expertise in that area than I do. But great question. Molly or Michael, anything you guys would like to say? We're kind of coming up on our time, so maybe would one of you like to close things out a little bit?
Well, one thing I can say, Dr. Gerber, and I really appreciate your overview of not only the various ways to approach and think about psychotherapy, but the research and a kind of a broad construct for us to think about what is it about psychotherapy that makes it so potent. And I think you're talking about the exposure elements, the ways in which the relationship becomes a new paradigm for relationships, whereby one can authentically connect with others in a non-judgmental atmosphere. and also the narrative that we tell about ourselves. So as I think about those elements, I think about the narrative of what Silver Hill treatment means. And one of the things that is important to me as the person who oversees all of our clinical care is that the narrative involves a couple of key things. One is that we meet people where they are, that we think about the array of evidence-based practices that are available, and that we are bringing the best of that care to every single patient. And I think it's incumbent upon us to embrace the diversity of ways of working and treating states of illness. And something that's very important to Molly and Dr. Gerber and I is that our approaches are really integrative, and that we, even though, for example, we have a number of people here who are trained in dialectical behavioral therapy and have a lot of experience in providing dialectical behavioral therapy, we know that approach is one that we are finding ways to increasingly build upon in terms of looking at, all these different models have enormous strengths. They also have limitations, and they actually also represent the diversity of humans. And so even as we think about diversity, wanting to ensure that our therapies are sensitive to the needs of all racial groups, people of all different gender identities, sexual orientation, ethnicity. These are all important elements of what it means to be human. And so I'm excited to be part of an organization that looks at embracing diversity and complexity and providing the best of science-informed care.
Thank you, Michael. Molly, you want to say any last comments before we say goodbye?
Sure. Thank you, Andrew, for giving such a great presentation, and Michael for all of your comments and thoughts. And hopefully this was helpful for people. I know that this kind of information is not easy to look up online or Google or understand without a professional really speaking directly to you and educating you on all of the research that we know in the field. So I'm very grateful for this presentation, and hopefully it was helpful for you all. Again, I can send this out. I will send this out to the entire group. The recording will be sent to your email address, the same email that I sent to invite you to this event. And we look forward to seeing you next week at the same time for another exciting presentation to be determined. So thank you for joining us today.
Bye, everybody. Thanks so much.
Bye now. Thank you. Thank you, everyone.